Play the second video, please. Thank you. So this was again a 65-year-old male patient on prostate medication. Came to me for surgery for cataract. You can see it's not a dense cataract. I put a dispersive viscoelastic on the pupil. The size of the pupil is 5.25 millimeter. Being a good surgeon, I thought I'll get away with any problem. Sometimes God is not always with you. That's a take-home message here. And I'm going ahead and doing my CCC. So the CCC will be about 5 millimeters in size. And if you have a new tip, which is a sharp tip, and a grade 0.5 cataract, a soft cataract, the tendency here is that whenever you try to go ahead and do phaco and occlude and try to chop and bring the nucleus into the anterior chamber, the sharp tip itself, the vacuum itself, is good enough to break the occlusion, and the nucleus drops back. So now you have a 5.25 millimeter pupil and a nice round CCC. Now watch what happens. This is a straightforward case, a soft cataract, a small pupil, and now see what happens. I'm going ahead and doing my phacoemulsification. It's becoming a plate because it's a soft cataract, okay? And you can see the side port, you can see the main incision, the pupil is trying to come back. So you saw that I held the iris once. Let's watch the same thing in slow motion. And now I'm again going to hold the iris by mistake. That's in slow motion. I'm not applying any phaco energy by mistake. It has been pulled. Now I'm thinking what next to do. Now I'm using my chopper to push the iris away because it's coming in the field of my phacoemulsification. And now what? So I think, okay, I'm still not a bad surgeon. I'm a good surgeon. I'll still get away with any issues. So I come out and at the same time notice your main incision, notice your side port, that the iris is trying to prolapse, okay? That's because, as I said, 65-year-old patient on prostate medication, I'm using a dispersive viscoelastic again, holding on to the pupil, thinking that this size of the pupil for a soft cataract is easy for a safe phacoemulsification. But do not push. One point take home message again, do not push your luck, right? You can have problems and do not have any ego. So we have lots of tools at our rescue today's world, and we have lots of things. And now the pupil has again started coming down on me. The straight one has become horizontal. Again, the side port is, the iris is trying to come out. The iris is coming out through the main wound, and the pupil has further come down to about 4.5 millimeter in size. So now the question is what? So we can use hooks. We can use a Suven Bhattacharya ring, or you can use a Malugan ring. Now, very, very important take-home message that in such scenarios, if you want to use any device, make sure that your CCC is not entrapped when you're trying to put a ring. Here I'm trying to put a Malugan ring. As you notice, I put in 2 parts of the loops inside and now the last part. And now my phacoemulsification becomes extremely safe. So I go ahead and do phacoemulsification. At one stage, I feel that my CCC is entrapped with the iris in one of the loops which is there in the Malugan ring. Here I'm going and removing the nucleus. I bring the nucleus to the level of the CCC, apply phaco energy, remove the whole nucleus, and that's fine. So now you'll notice that I'm adjusting the Malugan ring. That is it, that you can see the adjustment now. And I made sure that the CCC margin is away. I remove the Malugan ring after putting the IOL. I have to remove the viscoelastic. But mind you, friends, notice the size of the pupil. It's become 3 millimeters in size. Okay, the pupil is coming out to the main incision. Luckily, I use a cohesive viscoelastic, which is very easy to remove. It just comes out as a blob. There is really nothing much to worry here. And I'm making sure that all the viscoelastic in front of the lens, because the lens compartmentalizes the viscoelastic, is removed. So the viscoelastic in front of the lens and viscoelastic behind the lens, both will be removed, and it comes out as one blob. The iris is placed back into the anterior chamber. The wound is hydrated, and the lens, this is irrigation behind the lens to make sure that there's no viscoelastic at all. So you can see that the pupil has further come down to about 4 millimeters in size. Hydrate the wound, and procedure which actually caused an intraop miosis could be managed quite well because of all the tools that we have to our aid in surgery today. I think that ends my presentation. Thank you very much. And any questions, I'm looking forward.
Excellent, Kumar.
Thank you, Chitra.
Showed a situation which could happen in any of our hands. Now, the first instance is he was on a femtocataract platform. Although the cause of miosis was not the femtocataract, but we just need to remember.
It was not in a femtocataract. It was a normal case.
Oh, it was not on the femtocataract.
Yeah, because I did my Rhexis with the forceps.
Oh, you did it with the, okay.
So this was a normal 65.
I would want to say that the initial part of the miosis was not because the patient had enlarged prostate. I think it was that first catch of the iris which triggered the problem. And of course, then the other concept added on.
Yes.
Now, as he was doing phaco, all of us realized that he was trying to get to a chase of a fragment and get to impale it and get it forward and take it out. And when it was not happening at one point, he rotated it, tried to get approach to the other end. So essentially, it's very important for us to remember that when you're doing a very soft cataract, The vacuum should be just appropriate. You could retract the iris if the pupil is getting myotic, and you get to hold it. And at that time, the energy should not be high, because if you are using higher energy, then you are actually emulsifying the soft cataract and you lose occlusion. So anyway, he went about it to the best of his ability, and then he ended up with a bowl kind of a situation, which is something which has happened to all of us. So my question to Kumar is, before you thought of putting a Malugan ring, did you think of doing a hydroprolapse and, getting approached to a pole and getting it out or cartwheeling it out? I mean, you did it beautifully, the way you
Yeah,
showed
Chitra, you're
the
right. But
sequence
the
of
point
events.
here is my CCC is not very big. Okay. So my CCC, if I want to do a hydroprolapse and try to bring it out, I need a little larger CCC. Secondly, the pupil was a little small. Any procedure that you try to bring the nucleus out is going to rub your sphincter and the pupil will still further come down. So I prefer that we try to avoid this situation like this, because if anything like this you bring then, and I'm never not very comfortable of doing phacoemulsification in the anterior chamber. Only thing here what I feel is that even if I reduce my vacuum, okay, even if my vacuum was 60 and not 500 or not 300, believe me, it's the sharp tip. It was a brand new tip and a soft cataract. So moment you have a vacuum or whatever it is, it holds, the sharp tip goes through the nucleus, it sucks the nucleus out, and the rest of the nucleus falls back into the back, and the back forms again. So the biggest fear in a small pupil, in a 65-year-old male patient with prostate treatment with a floppy iris, is the pupil coming down on you and it becoming a plate. Then the plate will become extremely more difficult to handle. Then many times we have to make sure that the bevel down we go in, hold the nucleus. Again, the fear is sharp tip. It can go through and rip your posterior capsule. So this is just a thought that I thought that this was the easier way of managing.
There's one more question I have for you before I would want Dr. Shreyas to take over. Would you have a set plan that when you would use a ring or when you would use hooks? Do
So
you have?
that's a good question, ma'am. That the thought process here is whether whatever you use. Point here is if I knew this patient is already got this, had a prostate, it would have been wise that I put the ring on step one. So before I do my CCC, then this whole thing would have been avoided. So bottom line is, however good we are, sometimes we can face this. It all depends on economics. Hooks cost 500 rupees, no financial interest. The Suven Bhattacharya ring around 2,500 and the Malugan ring around 7,500. So it all depends on what access do you have at that moment. Only disadvantage with the hooks is you need to make 4 ports and you need to remove it. And it's not anatomically nice when it comes down because you'll have a few sphincter tears.
Not necessary. Probably each of us do what suits us best and which
Yes.
technology we are comfortable with. But I think there's one instant to my mind I would use hooks is if the anterior chamber is very shallow, then I would think about pushing in a Malugan's ring, and I would prefer to use a hook. Dr. Shreyash, can you take over and tell your thoughts on this? You're on mute.
Yeah, I've unmuted myself. Sorry. No, with regard to rings or hooks, I agree with sir that each of our preference and what we are comfortable with, and I think both of them work quite well in these situations. And like he said, I mean, the way the case started off with the pupil being 5.5, 6 millimeters, probably none of us would have thought of putting in hooks or rings. Maybe just a couple of points I'd like to emphasize here is the fact that what challenge most of us might face when we are doing a phaco in a soft cataract, which is basically what the challenge was in this case. I think in a soft cataract, the nucleus is a very precious commodity, and we have to really treat it with care. So the settings which I usually prefer is having a very high vacuum, very low energy. I try to occlude deep into the nucleus with just the high vacuum, and then do my direct chop, and then rotate it and do one more chop before I evacuate any pieces. So once you have 4 pieces, it becomes extremely easy. Probably the other thing where you hardly need nucleus is also maybe doing a hydrodelineation along with a hydrodissection. That also helps because the nucleus comes out very easily. You're able to, even if your chop is not complete, you're able to tumble out a portion of the nucleus, which then makes the nucleus evacuation easy. And then it's just the epinuclear sheet removal. So maybe just a couple of things which will help in any soft cataract and probably would have helped in this case.
Only one question here is that some doctors actually autoclave tips like that. Old tip, brand new tip. If it's a very hard cataract, use a brand new tip. If it's a very soft cataract, use an old tip. And this might also help your surgical technique. So this is what I think, that even if you use an old tip, this would not have happened. The nucleus would not have got sucked out in some portions and forming a plate. So that's one more.
I'd like to make a point here, especially for any beginner surgeons who are watching. One is that if you have a small pupil also, it's always possible to go underneath the pupil and make your rhexis actually larger than the pupil size. So don't get constrained by the pupil size absolutely. You can actually take it around so that it goes underneath and you get a larger rhexis size than the pupil. And then I like doing the procedure in soft cataracts where often, like you said, Dr. Kumar, that you get a purchase of the soft cataract and then suddenly the vacuum just takes it off and you find that you have lost that vacuum completely, that hole completely. In that case, what you can do is you can actually rotate it a bit and make it a bowl actually. And like Dr. Chitra said, you can try to hydroprolapse it out. And that does happen even with a 5.5 millimeter pupil. Though sometimes what might happen is it comes out of the rhexis and it gets constrained by the iris, the rim of the pupil. In which case also that's also perfectly fine enough. You just need it out of the rhexis and then you can just emulsify it in the back. So that's actually a nice way to deal with these plate kind of situations.
I think I would have to go on to the next speaker because
so one or two questions I just thought I'll ask, which were coming up.
One is Arup has a question to ask.
I'll just run through one or two. Of course, the malignant ring and the hooks you put under topical only, or is there another?
Topical.
So, do you give any intracameral or?
No. Yes, intracameral Xylocard.
So you will add intracameral Xylocard before you put the hooks.
Yes. No. It's my whole surgery is under topical, so every step is topical.
Okay. No, before you put the hooks, would you add intracameral or?
I really don't think it's necessary.
Okay.